If you see psychosis with abnormal movements, pause before you call it primary psychiatric illness. Movement signs are not background noise. They are anchors. And once you learn to recognize these anchors, your differential diagnosis becomes faster, sharper, and far more biological. Let us start with parkinsonism and rigidity. When you notice tremor, slowed movement, or that classic lead pipe stiffness, ask what neurological process is driving the presentation. Parkinson's disease often brings visual hallucinations that may look psychiatric but are rooted in neurodegeneration. Dementia with Lewy bodies adds fluctuating cognition and spontaneous Parkinsonism. If vertical gaze becomes limited, think about progressive supranuclear palsy. Chronic toxin exposure can produce irreversible Parkinsonism, especially with certain metals. Post-encephalitic syndromes may leave behind rigidity and delusional states. Severe rigidity with fever is never routine. That pattern should immediately raise concern for neuroleptic malignant syndrome or malignant catatonia, both of which are medical emergencies. Copper metabolism disorders can also produce rigidity that mimics idiopathic Parkinsonism, so always examine the liver, the eyes, and the neurological pattern together. Next comes chorea, those brief dance-like movements that rarely belong to functional illness alone. Huntington's disease classically progresses from movement change to delusional psychosis. Autoimmune chorea following streptococcal infection may present first with emotional or behavioral symptoms before the movements even begin. Self-injuring lip or tongue biting is a striking clue toward rare neurodegenerative disorders. Some genetic conditions resemble Huntington's disease but follow different inheritance patterns and timelines. Adult-onset iron deposition disorders may present with progressive chorea or dystonia, reminding you that metabolic causes often hide behind psychiatric labels. Dystonia and abnormal gait form another critical anchor. Twisting postures, unusual walking patterns, or sustained muscle contractions are never trivial findings. Copper metabolism disorders frequently present with dystonia as a dominant feature. Toxic exposures may produce a distinctive toe walking posture with flexed elbows. Storage disorders can evolve slowly, with dystonia appearing later in the disease course. Certain neurodegenerative syndromes produce characteristic MRI patterns alongside progressive posturing. A broad-based shuffling gait combined with cognitive changes and urinary symptoms should push you toward considering normal pressure hydrocephalus rather than primary psychosis. Now consider myoclonus and pathognomonic rhythms. Sudden jerks or repetitive rhythmic movements are powerful diagnostic clues. Rapidly progressive dementia with myoclonic jerks is a red flag for prion disease. Synchronized eye and jaw movements are highly specific for rare infectious etiologies and should never be dismissed as behavioral. Heavy metal toxicity may produce encephalopathy with prominent myoclonus and ataxia. Drug-induced toxicity, especially from serotonergic agents, can produce clonus and hyperreflexia that mimic agitation or severe anxiety but represent a toxic state. Ataxia is another anchor that reshapes your thinking. Incoordination, imbalance, or staggering gait points towards cerebellar involvement. Nutritional deficiency states may produce confusion, eye movement abnormalities, and ataxia together, forming a classic clinical triad. Genetic ataxia is often present gradually and may include psychiatric symptoms long before motor impairment becomes obvious. Some metabolic conditions mimic nutritional deficiencies with intermittent ataxia episodes, creating diagnostic confusion if the neurological exam is rushed. Finally, look for pyramidal signs. Weakness, hyperreflexia, or spasticity indicate corticospinal tract involvement. Acute onset focal deficits alongside delusional thinking may represent stroke rather than functional illness. Demyelinating disease can present with spasticity and motor weakness, and a small but significant subset develops psychosis. Degenerative motor neuron conditions occasionally overlap with frontotemporal syndromes, producing behavioral and psychotic symptoms. Certain metabolic leukodystrophies manifest in adulthood with progressive spastic paraparesis, and missing these signs delays life-changing investigations. Here is the rule you should remember. Psychosis alone is a symptom. Psychosis plus a movement abnormality is a diagnostic map. When you see tremor, chorea, dystonia, myoclonus, ataxia, or pyramidal signs, do not assume medication side effects until you have ruled out neurological and systemic causes. Train your eye to look for the motor anchor, because once you identify it, the differential diagnosis narrows from hundreds of psychiatric labels to a focused set of biological possibilities. That shift is what separates symptom management from true clinical reasoning.